So 3 years ago, when we started planning this conference, one of the first people that I was told that I had to involve was Dr. Ilan Feldberg. And so for 3 years, we've been seeing each other on Zoom, and it's such a pleasure to finally meet him today. So Ilan Feldberg is both a physician and a dentist, and we're going to have to recruit you for the American Academy of Developmental Medicine and Dentistry. He is the Chief Dental Surgeon for the Ministry of Welfare and Social Security, the dental branch. He runs and is in charge of 23 accessible and specialty equipped dental clinics throughout the entire country of Israel. He's operated by Akim Israel with highly trained and well-experienced staff, and he basically is providing the dental service to more than 20,000 patients with special needs, including those with intellectual and developmental disabilities, autism, rehabilitation patients, such as those with cerebral palsy, polio, and senior citizens from most socioeconomic grades. So thank you, Alana, for
Actually, you presented all of my presentation already, so I can just thank you. But I was told that lunch is waiting and I have to be short. So first of all, I want to thank the committee and head of it to Steve Perlman, who insisted that I will be invited here, and of course Shalva. And I want to present you our organization, which is a ministry organization. I'm part of the medical division, in the Ministry of Welfare and Social Security, which is headed by Dr. Sagit Ober-Alon. She's presenting something different in the South today, so she couldn't come. She apologized. To excuse my English, it's not so fluent. Okay. Thanks. So we are a dental branch in the health division of the Ministry of Welfare and Social Security. We have 23, as Steve said, 23 accessible and specially equipped dental clinics that are spread all over Israel, operated by Akim Israel, with highly trained and well-experienced durable staff, providing dental health service to more than 20,000 special patients. Okay, the budget is governmental. It's coming from the Ministry of Social Affairs, and it's according to population volume and scope of service, and we pay the staff, we insist to pay the staff globally and not fee-for-service, which is not the right way to do it with handicapped patients. I'll talk about it a little bit later. Okay, we have in our organization 3 basic professional principles. First one is the preventive and proactive dentistry. The second one is to use fixed, contrary to removable prosthesis. And the last one, which is not less important, is maximizing and practicing all means in order to prevent the need for general anesthesia. Our patients usually, in the literature, they are mentioned as if needing something like 20 or 50% general anesthesia in order to treat them in dental clinics, but we reduced it really significantly. For the first principle, for prevention proactive approach, we have a proactive annual dental meeting with the dentist to all our patients. Proactive dental hygienist treatment each 6 months. We're also working with outdoor clinic activity with portable dental kits in order to reach maximum potential special patients in the natural environment surrounded by the familiar friends. This is somewhere in the north. We have a dental kit. We developed it here in Israel, and then the other kit we developed with Osada. This is one of the leaders from Osada came to see how the kit is working here. The portable kit is also working. These are pictures taken from a Bedouin school in the south. Usually we use the portable kits for non-portable patients who live in residence. We come with the portable kits to treat them in their beds if it's difficult to bring them to our clinics. But we also use them for activities out of the clinics in order to reach for dental preventive procedures. This is also in the Bedouin school in the south. This is the portable kit working, and when we finish, we fold everything back and take it with us, leaving the patients that we saw with a new toothbrush and new toothpaste. The second principle is to work with fixed prosthetic dentistry. Adjustment to removable dental devices is extremely difficult with our population. We do dental implants with bone grafts and sinus lifts when needed. And these are routine practices in our clinics. We do something like 2,000 dental implants annually. And the last principle is normalizing dentistry by preventing anesthesia. Practicing all behavioral techniques suitable to each patient using the nitrous oxide, of course, and we use a lot in all our clinics, the protective medical stabilizations, the PAOH board, if anyone is familiar with it, I'll show some pictures. The staff income, as I said before, is based on global hours and not fee-for-service, because treating these patients based on fee-for-service is not profitable for any staff. So we insist that our staff will be paid globally and not fee-for-service. We succeed to manage 98% of our patients with treatments in our clinics and without the need for deep sedation or general anesthesia. All the treatments and the technologies and techniques that we use are practiced under informed consent of the patients or their guardians. If there is any need to emphasize the advantages and disadvantages of general anesthesia versus regular treatment, they are summarized here. And we use the behavioral techniques as I mentioned before, and all equipment needed to practice it. We have also in the last year, we bought a dental CT in laying posture, so we can take X-rays to patients that were not able to cooperate in regular dental X-rays places that try to take X-rays with them. This is one of our clinic. The PAOH board is on each chair all the time, not in use all the time, but it's on every chair, dental chair. And when we go out clinic, we also need use this PAOH board when we do activities out of clinics. Thank you.
So our next speaker, I have the honor of introducing, although he told me not to make a fuss. And I'm sure many of you know Steve. You're definitely better for it. And if you don't know him, you will know him after today. And you will be receiving emails from him all hours of the night. And you'll just become part of his inner circle. So Steve's the founder of the Special Olympics Healthy Athlete Program. He's the co-founder of the American Academy of Developmental Medicine and Dentistry, as well as the Special Care Dental Association. He was instrumental in the ADA changing its code of ethics to include people with disabilities, as well as the code of accreditations that Mark made reference to earlier. He's a clinical professor of pediatric dentistry at Boston University School of Dental Medicine, an adjunct professor of pediatric dentistry at the University of Pennsylvania, and he has tirelessly dedicated his life to this population and improving the quality of life for people with disabilities. And lastly, obviously, he's our new president of PAOH. Steve.
Thank you. So Israel, like many countries and people, can be a paradox. Prime Minister Golda Meir, known for her will of iron and heart of stone, had a granddaughter, Myra, born with Down syndrome. Golda Meir refused to ever see her and demanded to her son that she be institutionalized at birth. Deputy Prime Minister Yigal Allon had a daughter with severe disabilities, whom he placed in an institution in Scotland. On the other hand, we know that since 2014, the Israeli Defense Force initiated Special in Uniform, where over 1,000 young Israelis with intellectual and physical disabilities have served their country with pride. And in 2013, young soldiers with autism have served in the IDF's Selective Visual Intelligence Division, showing their value of acceptance and inclusion. Tikam Olam is the name of a project backed by the Ministry of Education, where over 10,000 students in the 9th grade have been exposed to the world of disabilities and accessibility. The program includes lectures about disabilities in the field of activities, opportunities for joint fun, such as hiking with children of their own age who have various disabilities. So roughly in 2021, 1 in 4 Israelis have a disability. Autism has tripled in the last decade. Boys being diagnosed now 1 in 48 births, and girls 1 in 223. Down syndrome, 1 in 1,000 births, and as typical all over the world, the incidence of ADHD is roughly 9.5%. So I've been charged today to talk to you about screwed. I didn't. Oh. Got it. Okay. So I'm going to talk about I can talk about the 70-year history of dental care for people with disabilities all over the world. 50 of my own and 20 from my mentors who were part of the original forming of special care dentistry. So if we want to know, the title of my program is going to be Origin to Outcome, and if you want to understand today, you really have to understand yesterday. So basically, in the world of dentistry prior to World War II, there was nothing that existed. And then pediatric dentists came into this, and it was only pediatric dentists that came into the picture. In the early 1990s, they started the Academy of Dentistry for the Handicapped. And I was proud, my mentor got me involved in the late 70s. And so it was such a small group. And so we needed to expand and we needed to have some more clout. So we joined together with the Academy of Geriatric Dentists and with the hospital dentists, and we formed special patient care dentistry in the United States. The counterpart on the global side was the International Association of Disability and Oral Health. And the only other players in the field, in the whole landscape of patients with special needs, were pediatric dentists. And in the United States, the American Academy of Pediatric Dentistry was started in 1947. So when I trained in the early 70s, pediatric dentists were the only people that took care of people with disabilities, and our charge was to take care of them through their lifetime, because there was nobody else to transition them to. The kiss of death for this whole population came when pediatric dentistry became an age-defined group. And now, as much as young as 12 and 14, the pediatric dentistry, the world of pediatric dentistry has transitions them, or tries to transition into the adult world, and we know that's been a total failure. So what are we going to do about this? Let's see if we can figure it out. So now I'll talk about my personal journey. So for the first 25 years of my practice, it was limited. I had a partner who was a pediatric dentist and an orthodontist. And so our practice was limited to dentistry for patients, for children and adolescents, orthodontics, and patients with special healthcare needs. And when I retired, I wound up having roughly about 1,200 patients in my practice with disabilities, and many of them were adults. And it was never because we were so good, it's because nobody else was doing it in the community, so we got stuck treating. We were basically the junkyard of dentistry. If any dentist in the community had somebody they didn't want to treat, it was under special needs. And so we did it. So the first 25 years, I was active in the, especially like I said, informing special care dentistry, and then my life changed 30 years ago when I got a call from Eunice Kennedy Shriver. So President Kennedy was, everybody here knows about the history of the Kennedy family. So Joe Kennedy, the family patriarch, was grooming his son to become president of the United States. And there was a sibling, Rosemary, who had some form of an intellectual disability. So today she could have been treated, I'm sure, by psychotropic drugs, but Rosemary was an embarrassment to the family. In those days, as it still is in many parts of the world, it's a stigma to have some family member with an intellectual disability. And so Joe thought that this would be an impediment in getting his sons to be president. And so at that time, he was ambassador to the United Kingdom, and when he came back to the United States, he met two surgeons who said they can cure Rosemary of her intellectual disability by doing a lobotomy. And without the permission of the family, he went ahead and had a lobotomy performed on Rosemary Kennedy. And it turned Rosemary from being this vibrant, beautiful woman as an integral part of the family into a vegetable, where she spent the remaining years of her life banished into an institution in Fort Alice in Wisconsin. So Rosemary had been hidden from the public forever, the forgotten Kennedy. And then I got a call 29 years ago from Eunice Shriver that her sister, Rosemary, who had been supposedly getting the best medical care in the world because there was so much guilt involved in the family, that Rosemary, who was treated, her dental problems were treated by a general practice residency, and they decided to edentulate her. And the legal guardians at the time were Senator Ted Kennedy and Eunice Kennedy Shriver, who was an American hero, the founder of Special Olympics, and the leader of one of the leaders of the disability rights movement in the United States and globally through Special Olympics. And the team of general practice, the team of residency team, wanted to edentulate Rosemary, but they needed the permission of those two legal guardians. And they refused to give them the permission, and they put on a search in the world for somebody to treat Rosemary, and they wound up picking me in Boston. So how sad is that situation? a pediatric dentist to treat a 63-year-old woman 2,500 miles away from where she lived. But it just shows the sad state of dental care for people with disabilities. And so the first question I had was to her family, her physician in charge, because she was medically compromised at 63. She had a lot of health issues. And so I had a one-shot window to do her oral rehabilitation. In other words, they're going to fly to Boston. I was going to rehabilitate her and then send her back. And so the first question I had to her primary care was, could she withstand roughly 5 hours of general anesthesia? And then second, if they couldn't fix the teeth, was there anything else that they wanted me to do? So sure enough, they'd never been able to do a good gynecology visit, and she needed plastic surgery on her face. And so I arranged for my team that I do with all my patients, and they flew Rosemary to Boston, and in 5 hours, we did the gynecology, we did the plastic surgery, and I restored every tooth in her mouth. Not one extraction, and she lived 13 more years and just had routine dental care. She never needed anything else, and you wonder how something like this could ever happen. So shortly thereafter that, when I called Mrs. Shriver to tell her that her sister was fine, it was pretty exciting because at that time, Maria Shriver was married to Arnold Schwarzenegger, and he was the Terminator, and Maria was having trouble with her pregnancy. I had to call the house all the time on Arnold Schwarzenegger's residence. Anyway, it was pretty exciting, but I called, when the case was finished, I called Mrs. Shriver and said that your sister's fine, no extractions, we did everything, and I'm going to send her home tomorrow back to Wisconsin. And she said, my family wants to meet you and thank you for what you did for my sister, but more important, if she had all these problems, what about all the people in the world with intellectual disabilities? And so 2 weeks later, I found myself at the Kennedy headquarters in Washington, D.C. And in the room was Eunice Kennedy Shriver, her husband, Sergeant Shriver, who was a bigger American hero. He founded the Peace Corps, the Job Corps, Office of Economic Opportunity, ran for vice president. An amazing hero, credited with saving Martin Luther King's life. Anyway, Sergeant Shriver, and there were 2 other people in the room, the head of the Kennedy Foundation, and Dr. Robert Cook, who's the pediatrician and the founder of developmental pediatrics in the world. He was at Hopkins at the time and the parent of 2 children with Krudicek syndrome. So Mrs. Shriver was tough, and she welcomed me and said, okay, you have 2 hours to talk to me about dental care for people with intellectual disabilities. And I said, I don't want to talk about dental care, I want to talk about health care for people with intellectual disabilities. And she said, what are you talking about? They get as good or better health care than the neurotypical population. And I'm Jewish and from New York, and I said, what rock are you living on, Mrs. Shriver, that you can even think this? And she said, no, they get better, they get better health care. She said, I am the champion in the world for people with intellectual disabilities. And I thought, in order for them to succeed in this world, it was number 1, education. So I fought for education. Number 2, what are they going to do when they grow up? Job opportunities and work, because every citizen has to feel useful. And the third thing was, where are they going to live? We're closing all the institutions down, people living in the community. I care about safe housing and where they live. And so she said, looked at me and said, I can't listen to this anymore. What are you going to do to fix the problem? I said, what am I going to do? I teach, I have a full-time practice, I have a family. And she said, no, I want you to bring health to people with intellectual disabilities all over the world. And so somebody had told me that if you know Mrs. Shriver, if you can somehow get her and convince her to use Special Olympics as a soapbox or a bully pulpit, then maybe you could do something. And so I said, Ms. Shriver, I'll be willing to give it a try if you let me use Special Olympics as a vehicle to get this point across. And so the first 25 years of Special Olympics, it was spent strictly sports, fitness, and self-esteem for people with intellectual disabilities. Not to be confused with Rick talked about Paralympics. Special Olympics, you have to have an underlying diagnosis to compete in Special Olympics. And there are over 5 million athletes in 175 countries. So it's a good platform to do. So the original mission statement of Special Olympics, and it's credited for giving acceptance to people and not pity, bringing people with intellectual disabilities out of the shadows and neglect and into the mainstream of life. And so I walked out of there with this charge and said, what I'm going to do. So I went to the dean of my school, Boston University, and I said, I think that we have an opportunity to change healthcare for people with ID all over the world using Special Olympics as a vehicle. And so he gave me the resources of the school, and in one weekend we screened 750 athletes, did a dental screening on 750 athletes and accessed them into the healthcare screening. And the feedback was so great. And even though, to take an organization of 25 years, the DNA, sports and fitness, and now to challenge them into bringing health into the organization was really I didn't realize how difficult it was going to be, because I thought it was an easy principle that everybody would join, but a lot of it was like, you know what, we don't need another mouth to feed at the trial. We have enough trouble raising what we do. But I always saw the vision that people would give money for health rather than they would give for sports, and certainly in developing nations, that was the thing. And then it hit me in one of the first Special Olympic Olympics, and then every 4 years we had an event. And my first World Games was in Ireland. And when I saw on the stage, Nelson Mandela, Bono, you two had not played in Ireland in 5 years, and they played. So on the stage at the same time, Nelson Mandela, Bono, Bill Clinton, Muhammad Ali. I saw with this, there was a chance that I could change healthcare for people all over the world. And so I started with a dental program. And basically it was all the frustrations and everything in my 25 years of practice that led up to creating an oral health initiative to both change the healthcare professional and the public's perception of the importance of oral health into overall health. And so we were going to do screenings, awareness, like Steve said, yes, about the awareness of the problems for parents, for caregivers, for the athletes themselves. Collect a body of knowledge, because we didn't have the knowledge. Implement changing curriculum, which has been a long road, but to work with that. And to serve, very important, to serve as advocates on standards and quality of care, ensure the parents, the caregivers, the group homes, that the most current information was available, and a sports injury prevention. We started a mouthguard program that every athlete competing in contact sports was able to get a mouthguard at our dental screening program. And so, and bringing in all the partners, corporate, private, working with the chief ministries of health all over the world, the CDC, and all these different agencies, public-private sponsorship. And the turning point, one of the next turning points, was the CDC, the Centers for Disease Control, came to me and says, yeah, you got a great program, but it's touchy-feely. We need you to collect the data for us, because people with intellectual disabilities, first of all, we know how many births there are maybe with spina bifida, Down syndrome, but we don't know autism, ADHD, all the other things. You can follow these people you are the only organization that can follow people through a lifetime and teach us what are the health problems that these people face as they age. So the best thing the CDC was, it was the CDC's people who gave me the screening program that we use today. So basically, whether you're screening in Tel Aviv, or in Mumbai, or in Grenada, any country in the world, if you're going to screen for our program, you have to be standardized so the data is great. And so we're present in 175 countries. We have over 5 million athletes. And the next step was how I transformed the dental program to become a major public health organization. So we went from dentistry, we went into medicine, we went into hearing, health promotion, and a Fit Feet program. So basically now we're performing comprehensive services for all of these. So we can't, yes, sometimes I've had mobile vans and we do minor dentistry, but we give hearing aids, and we change, and we actually can, at these big events, we actually provide the athlete with classes. and that's an amazing, I've been there when an athlete received a hearing aid at 25 years old for the first time. I've been there when an adult person has gotten a pair of glasses in a developing nation, has seen his mother for the first time in his life, and the experiences have been amazing. So how did we go? Now I'll take you on the journey. The first thing we did was, number one, we had to show everybody that, yes, healthcare is the most unsupported need for patients with special needs. So back in 2000, when I started the program, we hired Yale University, which we thought was the best public health program in the world, and we hired them to do the famous Yale report on the health status of people with mental retardation. The book, the entire 2 years that it took Yale to do this report, it was 153 pages. 153 pages. That's all we knew about the health status of people with mental retardation. We knew that the average lifespan in America of an African American with Down syndrome was 23. We knew the average lifespan of a white American was 56, double the amount. But we didn't know any of the other things. So we took this Yale report, and only the Kennedy family could have pulled this off at that time. And we gave it to the United States Senate, and we had the first ever Senate hearing on the health status of people with mental retardation. It was an amazing event. I had to pinch myself to actually believe that it was happening. It was in Anchorage, Alaska, and everybody in the federal government, every agency had to be there to listen to this conference. And at this conference, I got a one-on-one with Surgeon General David Satcher, who agreed that he had to put it on his agenda. And he kept his word, and before he left office, he had the first Surgeon General's Conference on health disparities for people with intellectual disabilities. And it was amazing, and it was like a who's who in everything from maternal and child care to women's health to all the government programs. And that was the next turning point in my career, because I started to get calls from physicians all over the country. You know, Steve, I met you at the conference. I'm a neurologist, and I specialize in seizures. I want to be part of your team. I'm an anesthesiologist in Arkansas. I specialize in people with craniofacial deformities. I'm a gastroenterologist in Washington, D.C. I do all the scoping for group homes in my area. And so we got together in Rick Rader's house at a meeting in Chattanooga, Tennessee, and we formed the American Academy of Developmental Medicine and Dentistry, and that's where I've been spending most of my time for the last 25 years, because these people are amazing, and together we could make a change, and we have. Because of our work, the American Medical Association declared in 2010, declared people with intellectual disabilities a medically underserved population in our country. In 2014, the American Dental Association approved people with ID as a dentally underserved population. And how have we changed? The biggest change that we did was just changing the curriculum. For 25 years, I've been after dental schools to change, myself and colleagues have been asked to change dental school curriculum from basically nothing, because the only charge in dental schools was diagnosis and treatment planning. You can graduate dental hygiene school without ever having a patient visit with a patient with disabilities. And so no matter what, we heard from the deans, I don't have the faculty to teach it, we can't make any money in the schools doing it. So it's not happening. But then, thanks to Dr. Rader and the input, the National Council on Disabilities said, we're gonna fix this problem for you. And how are they gonna fix it? They indicted the American Dental Association for violating the Americans with Disabilities Act. And they said, and how did they fix it? Just by inserting the word disability in the code of ethics of the dental profession. It was a stroke of, I could never figure it out, but the attorneys did. And so basically, the code of the dental profession was prior, a dentist could not refuse to treat a patient because of age, sex, gender, whatever it was going on. The ticket was always, whenever a parent or caregiver would call up to the dental office to try and get care, it was like, I never got any training in dental school and I don't get reimbursed for it. Just by inserting the word disability in the code of ethics, meant that not, and it's not, of course that every dental professional may not have the skill to treat the patient that's there, but it didn't end with a phone call of like, I don't do it, good luck trying to find somebody. It came that it's the dentist, the person at the other end of the phone had the responsibility of putting that person into a dental office on somebody. So this is the new code of ethics that was adopted by, so dentists serving the public cannot refuse to treat a patient because of race, creed, color, gender, sexual orientation, gender identity, national origin, or disability. It's amazing how that one word is changing the whole landscape of dental education in this country. So if you go to the AADMD website, there are at least 25 different policies that we have made, and I don't have the, I wish I had the time to go into, but some of the things that we've done was we realized that vitamin D, there's such a high incidence of osteoporosis, bone problems, and density problems in patients with special needs. And so the guidelines, we realized that seizure medication negates vitamin D absorption. So we went to the top people in the country and said, would you help us change the guidelines of vitamin D for people with intellectual disability? And the American Academy of Endocrinology changed the guidelines strictly based on the work that AADMD did. When COVID came up, we were the first organization and the leading organization that had a policy of ventilators, because if there was going to be a shortage of ventilators, we knew that people with disabilities and intellectual would be discriminated against, because in the emergency room, when somebody comes in, is the ventilator going to go to a 23-year-old nonverbal patient with cerebral palsy who's had 25 admissions in the last year with aspiration pneumonia, or is it going to be given to somebody who's working and has several children and a family to support? So we needed to protect our patients. So we came out with a ventilator policy. We came out with a hospital visitation right, because remember in early COVID that you weren't allowed family members or anybody in the hospital. Well, what are they going to do? Deposit a 30-year-old nonverbal person with autism in an emergency room and the care that he's going to get in the hospital? So hospital visitation rights for people with disabilities. We talked about end-of-life planning, the Ashley X case, which was growth attenuation therapy, where parents had breast buds, uterus. They wanted their child to be a pillow child for the rest of their life because they were afraid to turn it into an institution. So they had growth it's being done. Take out the breast buds, the child would always be a pillow child for the rest of their life, so the parents can take them. Use of electric shock, and in the United States still, the term mental retardation is still written in death certificates in many states. So, I want to talk to you, just the last few minutes I have, I just want to talk to you about real life situations that we've done in the Academy that I'm so proud of. So Amelia is a 3-year-old child with Wolff-Hirschhorn syndrome, and Amelia was told by her physicians that she had 3 to 6 months to live, and she needed a transplant, and the parents went to Children's Hospital in Philadelphia, certainly one of the leading children's hospitals in the world, and the parents, both school teachers, brought Amelia, and when they walked in to meet the transplant team, there were lawyers and social workers and counselors in the room, and the head of the transplant team looked at the parents and said, yes, your daughter needs this transplant to survive, but we don't want to waste the time of our transplant team on your daughter who has significant intellectual disabilities. And the parents walked out of the room numb, and they said, are we really hearing this, that in this day and age today, that somebody would actually tell us that? And so they went on a blog, and a colleague of mine picked it up, and the Academy of Pediatrics, nobody came to help this family in need except the ADMD, a bunch of pirates and renegades. And because we don't obey any laws, and Dr. Rader, Rick, who at that time was head of the policy committee, wrote a paper within 2 weeks. I'm proud to say that we had a paper before the ethics committee of Children's Hospital And let me see, I just wanted to say, it is because of the history, legacy, and commitment of the Children's Hospital of Philadelphia that AD&D is disappointed and dismayed to learn that they've refused a kidney transplant to a girl named Amelia because of her mental delay. And the mother was the kidney donor. That's the saddest part of it. The mother was the donor. So it wasn't going to a donor bank, but the fact that they would actually feel that this child was not worth a kidney is hard to believe. So anyway, it is the opinion that transplant centers begin to embrace the idea that more than organs are being transplanted. What is hopefully transplanted is the notion of dignity, justice, and humanity, the very triumvirate philosophy that we hope will continue. I'm proud to tell you that Children's Hospital reversed the decision. Amelia got her kidney, and to the next meeting of the AD&D, she brought her child and brought her before the group and said, if it wasn't for you people here, I would be visiting her cemetery today, so thank you. At the last World Games and Special Olympics, this athlete went through my dental screening program, and the story, he's from Namibia, and when he was young, the principal of his school told the parents that he doesn't even look like a human being, and he cannot come to school anymore because the students just make fun of him, and we can't control the bullying. And so Elisa lived in social isolation all these years at home, just homeschooled by his parents and friends. And then somebody found out about him at Special Olympics, and they went to him. And they got it turned out he's a fabulous soccer player, and he made the team, Special Olympics team, participating in the World Games. And when we saw him in our health screening, and we brought him over to all the various disciplines, we couldn't tell whether this is a tumor growing or not. So he was having difficulty breathing at that time, and he was losing his vision. And we went to the chief health officer of the Emirates, and we said, if we send him back to his country, he will die in a few years. And so the Emirates agreed to treat him, and he's currently living there with his family, and they're providing all the medical care that he needs. And this is a picture of him at Christmas time a year later, when nobody really cared about him his whole life. And here he is celebrating with the people in Special Olympics. You also have to become advocates in your practice. So in this world, every parent gets so, we all know, because everybody in this room that's here for the same reason, we all know that parents and caregivers get so beaten up. And this was a little girl in my practice, Gracie. So Gracie, she looks like this sweet little girl, but actually I had to immobilize every time, no matter what behavior modification I tried. You needed a SWAT team to get this kid into a dental chair. And so she looks like she's so sweet, but great. So Gracie was born with Down syndrome and had the tetralogy of Fallot, and in her open heart surgery, after post-op, she developed a severe infection of the leg, and one leg grew. It was significantly shorter than the other. So she's got Down syndrome, she's legally blind, and she's got G-tube fed. And so the parents, the only child, and the parents take such great care of her. And so the at Children's Hospital in Boston, the head of orthopedics said to them when she was at this age of 12 or 14, she said, we now have to amputate the leg and make her a prosthesis because it's the only way that she could grow. And so the parents just didn't have, they said to the doctor, she's blind, she's blind, legally blind, she's got Down syndrome, she took, we can't do this, we can't amputate the leg. And every 6 months the physician would bully them and to say, I can't believe you haven't done, I'm the world's expert in this is what needs to be done. The parents went to Johns Hopkins in Pennsylvania, another top hospital in the world, and the physician looked at her and said, I'm not going to disagree with this guy in Boston. He's one of the world's authority on this situation. And so they came back disgruntled. They couldn't believe it, had a fight with the doctor. They said, at least examine her and give us your own opinion. And he did, but he still agreed with her. And then they came to me as a friend and as their whole dental home. And so I went out to my AD&D colleagues, and there's a physician, he's actually an Israeli physician in Florida who specializes in Little Anthony. and they went down to see him, and he didn't look at a child with all these disabilities. He saw a leg that he could fix, and he said, I can fix this. And there she is today, walking fine. And I told the, I said to the father and the mother, I said, we need to tell your story. You need to at least write an article for us or something. And they said that they came within an inch of amputating their daughter's leg because of being bullied by a physician who was so arrogant and said that he knew what the best thing for this. So as dental professionals with our patients in our practice, they need us to be the best advocates for their care that they could be. So maybe about 10 years ago, this gentleman was sitting in my waiting room, and it was summertime, he was wearing shorts, and he has no arms, and he has no legs, due to a medical malpractice case. And when he came time for the hygienist to call him to visit, I said, you know, I'm a pediatric dentist, you realize that? And he said, I've been to like 25 dental offices, and nobody will treat me. I said, why? He said, I don't know why. I'm as healthy as anybody else. I just have no arms. I don't have any arms and any legs. And so I've been treating him for all these years. And then several years ago, he came to me and said, I am going to be the first person to get bilateral arm transplants at the Brigham in Boston. And then there he is. Can you believe it? Bilateral arm transplants, the first human being. And here we are, and I just want to say that the fact that our profession, our colleagues deny treating somebody like this for no reason. It's just that looking at somebody, it's you know, my whole career it's been how to change the system. And yes, it's like, okay, we need more educational professionals. Yes, we need better reimbursement systems. But it's much deeper than that. It's the stigma that we all have, that we attach to, and in many societies, it's their low self-esteem, their burdens on society, their financial, we have to support them for the rest of their life. What is their worth as everybody else? So my life has been a lot richer by in having an inclusive world that I live in, treating patients with disabilities. In Israel, you know, I would think that Israel would have great data, but in my school, we have hundreds of thousands of screenings, and the burden of disease in our Special Olympic result, and yes, it was a small, but look at global, the numbers are 275,000 screenings. It was the burden of disease out of 556 athletes participating in a program, 106 had pain at the time of their competition. Had pain. Untreated, the numbers are terrible. Gingival signs, 70% had gingival signs, and urgent. So we have to do a better job in this country of treating patients with special needs. We just have to. And if there's one legacy that comes out of this meeting, is we have to do a better job here. And so one of the proudest things that we're doing now, Rick is the editor, but Helen Journal, so the ADMD has decided to come out with its own journal now. It's called helenjournal.org. It's free, a subscription is free, and the audience is for parents, caregivers, and healthcare professionals. And we've published 5 issues. I encourage anybody in this audience that wants to contribute in any way to please do so. We need to hear the stories that are out there. And thank you, everybody, for coming. Yeah. So we're not going to break for lunch, and if everybody can be perfect timing, if everybody can be back at 1 o'clock, that would be great. Thank you, everybody.
Real quick before we go on a break, I just want to take this time to thank our sponsors for the event, Henry Schein Cares, the Robert Shatner Foundation, and then the ADA Foundation, and then obviously our tremendous partners, Shalva, Penn University and Hebrew University, and our great friends at BetISI who helped us put all of this together. So thank you all so much, and I want to make sure everyone grabs the PAOH brochure that the lovely Ms. Courtney put together. It explains a little bit more about PAOH, who we are, what what our mission is, and some of the great work that we're doing. So we really encourage you guys to do that as well. It's right there. So okay, enjoy lunch. Thank you, everybody.